Radiograph alone, and today I am very fortunate that I am in the era of CT. And how I learn radiographs is I usually look at the CT and then I go back to the test radiograph and retrospectively learn. And yes, today also I think I'm more comfortable with CT, and sometimes residents from other units bring a chest radiograph, so I do have some clarification before reporting. So, in general, conventional CT, how is HRCT more advantageous, and how does it give us more knowledge? In a conventional CT, typically the slice thickness is around 5 mm, maybe 10 mm, and they are at intervals. So, a lot of information can be skipped. Whereas in an HRCT, the slice thickness can be as low as 0.6 to 2. At our institution, we are taking 1 mm slice thickness, and it can vary between 0.6 to 2. Why do we need an HRCT? If a general CT is showing us a finding, why do we need it? So I often give this example where this is in class 10, where my biology teacher described this. You slice a cucumber, take a thick slice, you'll appreciate the seeds, probably the pulp inside. But if the same cucumber is sliced as thin as 1 mm, we see a lot more. We see all the venules, the entire pattern, and that's what HRCT is doing to the lung. So here is an example. We can see these blotches, yes, very well. But what are these blotches actually? This is actually a thickened interstitium. And this means something. This information will tell us whether the patient is suffering from interstitial lung disease or just simply consolidation. So HRCT anatomy is not the lobes, the fissures or segments. The basic model of HRCT anatomy is the secondary pulmonary lobule, and which is formed by interlobular septa, the septa between each lobule, a centrilobular region, and the remaining lobular parenchyma. So this is what each secondary pulmonary lobule would look like. The centrilobular portion that would contain bronchus and the accompanying pulmonary artery. And the veins are all along, the veins and lymphatics are along the interstitium. They run along the interstitium. A colorful diagram of the same. This is the pleural surface. So this is the interlobular interstitium between two lobules. The pulmonary artery accompanied by the bronchus, and this is the centrilobular region. The pulmonary veins just limiting themselves to the periphery. So how do we describe findings on an HRCT? We need to identify the pattern of the disease, whether it is nodular or just some lines, a big blotch of consolidation. And then we need to put these findings, are they affecting the upper segments, lower segments, central field, peripheral field, and this is how we reach a differential diagnosis. And the most important after reaching a differential is get to know the clinical history. So these shadows that we see on an HRCT can be nodular, linear, reticular, a lace-like pattern, simply ground glass, a thin veil, transparent veil on the lung, or consolidation, an opaque consolidation. So we'll begin with nodular shadows. These tiny nodules are often picked up on HRCT chest. Even on conventional CT they can be missed, and they are a very important clue to diagnosis. So these nodules can either be centrilobular, as I showed in the model, right in the center of the lobule. These are all centrilobular nodules. They can be randomly scattered, or they may even follow the lymphatics, peribronchovascular interstitium. Depending on this distribution, we can taper to at least first 2 or 3 differentials. And with the history, you might just take the diagnosis. So these are a long exhaustive list of centrilobular nodules, but this should not discourage us. With the appropriate clinical history, examination, distribution of the lesions. As I said, we can taper our differentials to top 2, and sometimes 1, we can just hit the nail on its head. So almost inevitably seen in all infections, inflammatory lesions. Common ones are hypersensitivity pneumonitis, endobronchial spread of tumor, part of an angiocentric disease. Central portion is being affected, as in vasculitis, and in perilymphatic disease, commonest being sarcoidosis. These are the common diseases we encounter. Tree bud is a very commonly used terminology. What does it mean? So these are the tiny centrilobular nodules, and the terminal bronchiole that is supplying these nodules is actually filled with slough, pus, fluid, and it is clogged, and so it is forming the branches on which the leaves are sitting. That's the tree bud. So the pathology is here. This is just a blockage of those terminal bronchioles by either pus or fluid. Typically, again seen in almost all infections. But there are certain non-infectious pathologies, of which the common ones are ABPH, where the telltale sign is there will be bronchiectasis, central bronchiectasis, mucus plugging, and then you see the stream bud appearance of nodules. Other causes are cystic fibrosis and bronchiolitis. And I've already talked about the perilymphatic distribution of nodules, very typically seen in sarcoidosis. However, a close differential would be lymphangitic spread of tumor. We would be aware of history of tumor in such a patient, so not difficult. And there can be randomly scattered nodules. These are the miliary nodules. Common examples: miliary tuberculosis, viral pneumonias, miliary metastasis, and very early stage of Langerhans cell histiocytosis. Because here the nodules, the first stage of Langerhans cell, the nodules will appear, they will break down and large, form bizarre cystic cavities, and that's how the pathology starts. And sarcoidosis also the first early presentation of lung findings can start with nodules. So just to summarize, these are the randomly scattered nodules. They will not keep themselves to a particular domain. They will be all over the lung, as in miliary TB, miliary Mets. These are centrilobular nodules, confined to the centralmost portion of the secondary lobule, may or may not have associated interstitial thickening, may or may not have associated mucus plugging or clogging of the bronchioles. So they may or may not give rise to tree bud. And peribronchovascular interstitium, the perilymphatic nodules, typically seen in sarcoid, but a close differential would be lymphangitis carcinosa. So these were the nodules. Talking about the linear abnormalities, they may be seen as interlobular interstitial thickening between each lobule, parenchymal bands, and subpleural lines. So this can be very smooth, neat thickening, or sometimes very coarse looking, or reticulonodular looking, and sometimes it can be very thick, as in cases of fibrosis. So, common causes of smooth interlobular thickening is pulmonary edema, lymphangitic spread of carcinoma. In early stages, it will be smooth, veno-occlusive disease, and others. And this is again a different, showing you a pattern along the interstitium. There is thickening. This is interlobular interstitial thickening. We can actually identify lobules. These are lobules being identified, typically 1 to 1.5 centimeter in size. So these are all different cases. This is a case of pulmonary hemorrhage, pulmonary edema, and this is a case of lymphangitic spread of tumor. We can see ipsilateral pleural effusion. This is localized to one lung, predominantly one region of the lung. The other lung is free of the disease. Then there is nodular interlobular septal thickening. So again, sometimes we will see thickened interstitium and multiple nodules traversing along it. Again, it is the upper zones that are affected, we would think, and bilateral symmetrical, we will think about sarcoidosis. If it is just in one zone, lymphangitic spread of tumor, other causes are silicosis, amyloidosis. Then parenchymal bands. Now, as the thickening increases, so from linear opacities we move towards bands. So these bands are non-tapering reticular opacities to 5 centimeters in length, often perpendicular to the pleural surface. Often perpendicular to the pleural surface. Seen commonly with asbestosis, but in later stages of sarcoidosis, when fibrosis is the most dominating finding, then we can see these bands. And this is actually a case of sarcoidosis where we have reached the end stage of the disease with thick fibrosis, thick interstitial thickening bands, fractional rhomboidesis. Fine subpleural lines. Sometimes we come across this finding, non-specific finding. It may represent a fine linear atelectasis. Patient has not been breathing properly, recent post-cholecystectomy patient, or liver abscess, not breathing well, so you get this fine atelectasis. Reticular. Reticular is when it's not just one zone of interstitium that is affected. The entire parenchyma, the entire framework is edematous or fibrotic, and it's a diffuse disease. So this is how we get this lacy pattern, crisscross, everything is intersecting each other. Very commonly seen in IPF and in chronic stages of hypersensitivity pneumonitis. So this is a reticular pattern. Then comes the ground glassing. Very common finding on HRCP. Ground glassing is just a subtle increase in laziness, but it doesn't obscure the underlying anatomy, doesn't obscure the underlying vessels or the bronchi. You can still, this is see-through, you can still see the parenchyma through this. It can be very non-specific, but it is a very important finding because it tells us that yes, there is a disease which is potentially curable. It is very, very early. We may not be able to give the diagnosis at that moment, but if we follow up this patient, these GGOs will either disappear or, if not treated in time, they will finally form a lung pattern. So we don't let this patient just go away. We need to follow him on. So ground glass opacities in acute conditions such as pulmonary hemorrhage, ARDS to start with, but later they will form consolidations. This is a case of pneumocystis jirovecii, bilateral upper lobe symmetrical ground glass opacities. We have a patient's background with a reduced CD4 count. Patient is having dyspnea, so things fall in place. And ground glass opacities can also be in chronic diseases, as in non-specific interstitial pneumonias and chronic stages of hypersensitivity pneumonitis. These are certain examples. So this is a long-standing consolidation, not resolving, but around it is an area of ground glass opacity. So this pathology is actually expanding. A case of bronchoalveolar carcinoma. And this is a chronic stage of hypersensitivity pneumonitis. There is thickening of the interstitium, very coarse thickening, suggesting that yes, fibrosis has started taking place. You can also see some fine nodules scattered throughout the parenchyma. And large areas of ground glass opacity, so the disease is still progressive, it is still there. So then comes crazy paving. The entire framework is thickened, coarse, and this is how crazy paving appears as. Very, very typical of the first 2-3 conditions: alveoloproteinosis, acute interstitial pneumonia, and sometimes pulmonary edema and hemorrhage also. This appearance is called crazy paving, where you see diffuse ground glass opacity superimposed with a thickened interstitium. So the last of these categories of lung airspace opacification is consolidation, and consolidations can be central, peripheral, multiple, lobar, and their distribution also gives us a clue to diagnosis. So this is a predominantly peripheral, multiple small consolidations of organizing pneumonia, and this is, or we can give a differential of eosinophilic pneumonia if the patient has peripheral eosinophilia. And this is also peripheral consolidations. There were multiple consolidations which have now coalesced, and this was a cryptogenic organizing pneumonia. This also is chronic eosinophilic pneumonia, multiple peripheral consolidations in this patient with peripheral eosinophilia. Case of bronchoalveolar carcinoma with surrounding GGOs. Sometimes bronchoalveolar carcinoma will have multiple cystic spaces within it, and that time it is easier to diagnose if we see the multiple cystic spaces and it's a long-standing consolidation, that is pathognomic. So this is about, I have discussed about the things that are white or bright in CT, whether they are nodules, whether they are lines or airspace opacities. Now we will classify lesions that are dark on CT. These can be cysts or bronchiectasis. So, and honeycombing comes under bronchiectasis. So, bronchiectasis is localized irreversible bronchial dilatation, often associated with thickening of the bronchial wall. And this is a typical appearance which we call the signet ring. Normally, the ratio of the artery and the accompanying bronchus is 1:1. But the very look of it, we can make out that the bronchus is larger than the artery, and the artery is forming the signet ring appearance. It can be, the pattern of bronchiectasis can be cylindrical, varicose, cystic. So this is an example of cystic bronchiectasis. Tractional bronchiectasis. The very word itself says that there is traction from somewhere. And what causes this traction? Diseases that have fibrosis, could be a post-granulomatous infection sequelae, can be a fibrotic disease, interstitial, end-stage interstitial lung disease, such as UIP. So there is a lot of traction from the surrounding parenchyma, and the bronchi get stretched, their walls get stretched out, and this is how the tractional bronchiectasis appears. This is a typical example of tractional bronchiectasis. There is honeycombing, so it's like a beehive appearance. The honeycombing will always start from the pleural surface, and these cystic spaces will then march anteriorly towards the central lung. So this is a typical honeycombing that we are seeing here, and with a lot of fibrosis, a lot of interstitial thickening we are seeing, which here in this case depicts fibrosis. Then there is lymphangiomatosis, exclusively seen in women, usually of the reproductive age group. There will be multiple numerous cysts, and the intervening lung parenchyma is normal. Langerhans cells. In my previous few slides, I had mentioned that they, in the beginning, they actually start with multiple tiny nodules. These nodules then grow, cavitate, and form large, bizarre cysts of varying sizes. So these are the thick walled cysts of varying sizes. We can still identify some nodules, some smaller nodules that are cavitating, some bizarre cavities, like bizarre cysts, typically seen in smokers and predominantly in the upper zones. Then without walls. So in this category we have emphysema, and types of emphysema we know: centrilobular, panaceal, paraseptal, cicatricial. So this is a centrilobular emphysema. So the lobule is affected. Centrilobular emphysema seen in smokers. Paraseptal emphysema usually associated with centrilobular. And with this I would like to summarize. We first identify the pathology, whether we are looking at nodules, is there associated interstitial involvement, is there a consolidation, and then we answer these questions. Is it in the upper lung fields, as in sarcoidosis, lower lung fields, UIP, usual interstitial pneumonia? Is it central, as in pulmonary edema? Is it peripheral, such as a bronchoalveolar carcinoma or a chronic eosinophilic pneumonia? Is there associated pleural effusion, lung infections, pneumonic effusion, or lymphangitic spread of tumor will have the ipsilateral effusion? Is there any hilar lymph node enlargement, sarcoidosis? Is there any other mediastinal lymph node, tuberculosis, malignancy, lung malignancy? So these features, in addition with the HRCT framework that we just analyzed, will help us reach a close differential and in the end presenting symptoms of the patient and what the clinician has to offer us in the information.